My name is Dr. Patricia Bennett. I'm a surgically trained podiatrist, and I specialize in complications of the diabetic foot and advanced wound care.
My name is Dr. May Delacazada. I am board certified in emergency medicine with a subspecialty in medical toxicology.
I'm Dr. Sandra Adams. I'm a molecular virologist and professor of biology. Molecular virologists study the genetic material and proteins of viruses to provide information on how to treat them.
Good morning. My name is Dr. Erica David Park, and I'd like to welcome you to the virtual conference on health disparities in diabetes, hypertension, obesity, and COVID-19 complications. This is brought to you today by the Williams Forum for Diabetic Education and Healthcare. Now, to tell you briefly about myself, I am a board-certified specialist in physical medicine and rehabilitation. So my focus in medicine is on outcomes after hospitalizations, decreasing disability, improving function, and improving quality of life. I am a part of the Williams Forum and will be moderating today's event. To give you a bit of background about the Williams Forum, the Williams Forum for Diabetic Education and Healthcare is a nonprofit that was founded by Dr. Patricia Williams Bennett in 2013. The mission of the Williams Forum is to reduce and eliminate healthcare disparities in the greater Newark, New Jersey area, along with other predominantly African American and Latino communities. African American and Latino communities are disproportionately affected by the detrimental effects of uncontrolled diabetes, along with many other chronic medical conditions. Diabetes in particular is the main focus of the Williams Forum. Now, according to data by the Centers for Disease Control, 34.2 million Americans, or just over 1 in 10, are diabetic. An additional 88 million are pre-diabetic. There is a large burden, and particularly a large economic burden, as a result of diabetes. Healthcare costs are 2.3 times greater in people who have diabetes than those who do not. And also, based on recent data published by the American Diabetes Association, the annual cost of diabetes in the United States is $327 billion. Now, diabetes can be managed when it is diagnosed early and treated appropriately. However, when it's left untreated or poorly treated, there can be many complications. Over time, diabetes can cause damage to many organ systems in the body, and this is referred to as end organ damage. Some examples of complications are diabetics can have hypertension or high blood pressure, also heart disease. This can lead to strokes and to issues with chronic blood flow issues. There can be eye disease. Untreated diabetes can lead to a variety of different eye problems, resulting in blindness and reduced vision. In fact, diabetes is the #1 cause of acquired blindness in people under the age of 65. There can be kidney disease, which is also called nephropathy. In extreme cases, diabetes can cause kidney failure. This can result in the need to be on dialysis. In fact, diabetes is the #1 reasons that Americans need to be on dialysis. There can be nerve damage. This is called neuropathy. Diabetics can experience symptoms like pain, numbness, and tingling in their hands and feet. So issues like joint problems and ulcers are very common in diabetics. And if treated properly, these can be helped with the appropriate treatment. However, if left untreated, it can lead to infections that can ultimately result in amputations. Every day, 230 Americans with diabetes have to undergo an amputation. It's particularly seen frequently in my field, where we deal with prosthetic legs and the rehabilitation that occurs after that. So it is possible to regain function after an amputation with the right treatment and the right care. However, it's really best to avoid that situation in the first place, because the impact on quality of life is pretty substantial. In addition, diabetics can experience many different types of infections. Diabetics are at risk for various types of infections because of the fact that their immune systems are at a lesser level. So they're more risk for infections because of that weakened immune system. So the Williams Forum is strongly committed to effecting positive change in healthcare. We strive to make underserved populations stronger through educational and health forums that benefit our communities. You may have heard the phrase, knowledge is power. Well, that couldn't be more true. A knowledgeable community is a healthier community. We do our best to maximize knowledge and to educate through speakers bureaus, community forums, health fairs, and web-based information. The Williams Forum also interacts directly with at-risk community groups, grassroots organizations, and healthcare providers. Of note is that the Williams Forum relies entirely on grants and donations to fund all of these activities. Now, under normal circumstances, much of the Williams Forum's outreach and education would have been in person in the community. Now, health disparities are differences in health between groups. There can be a higher burden of illness, disability, or even death in some groups versus others. According to the American Diabetes Association, racial and ethnic minorities have a higher prevalence and greater burden of diabetes than compared to white Americans. The risk of developing diabetes is 77% higher in Americans of African descent and 66% higher in Latino Americans. When we look at other conditions like hypertension or high blood pressure, there are also racial and ethnic health disparities. In the United States, 54% of Black adults have hypertension compared to 46% of white adults. We also see health disparities in lung disease. Again, according to data by the Centers for Disease Control, African Americans die of asthma at much higher rates than other racial groups. African Americans also have the highest rates of obesity at 49.6%, with Latino Americans unfortunately second in line at 44.8%. So these are just unfortunately a few examples, and there are many more examples of health disparities, but these are just a few for us to start with. Now, when we get to the large elephant in the room of COVID-19, we again see these unfortunate, disturbing health disparities. And then the big question is, why is that? So there are several factors that we have at play here. And some of the major factors involve what are called the social determinants of health. So when stay-at-home orders were put in place as a result of COVID-19, there are some people who were able to telecommute and just work from home and continue doing their normal jobs. However, for someone who's an essential worker, that's not an option. Due to the nature of their work, essential workers had to actually go in and were exposed to more people and more likely to contract the virus as a result of that increased exposure. When we're looking at environment, members of racial minority groups are generally more likely to live in multi-generational homes. So we can end up with a situation in which a younger essential worker has to go to work, may contract COVID-19, may experience a milder case of the virus, but then they live in a multi-generational home and will bring it home to an older member of the family who could develop a more severe case or potentially a deadly case. Regarding food, there are some neighborhoods in which many members of racial minorities live where there's less access to healthy food options. For instance, there's a term known as a food desert. This is an area where there may be many food options, but most of them are not nutritious ones. So there may be a lot of fast food restaurants, but no grocery stores that sell affordable, healthy fruits and vegetables. Poor nutrition unfortunately results in poor health outcomes, such as increased rates of diabetes, increased rates of obesity, increased rates of high blood pressure. So these increased rates of these chronic illnesses would have an impact on the situation with COVID-19. And the healthcare system itself can, unfortunately, be part of the problem. Some who are racial minorities do not have health insurance at all. Others have health insurance, but it's inadequate. And there can be situations in which there are not enough healthcare providers available in certain neighborhoods, or not enough doctors who accept specific insurances. There can be concerns of poor quality of care. In fact, there can be another issue of implicit bias among some healthcare providers. So there's evidence that some people of color may receive substandard care and are not provided with all of the all of the healthcare and treatment options that white Americans may receive. So all of these factors together came into play when we were talking about the COVID-19 pandemic. So at the Williams Forum, we realized that these may be confusing and somewhat frightening times. There are a lot of mixed messages out there about COVID-19, about diabetes, about hypertension, about vaccines, and about the healthcare system in general. So we at the Williams Forum would like to help to answer your questions and to alleviate some of your concerns. Because as I mentioned before, knowledge is power. So today, we have a panel of experts who can help. We have on our roster Dr. Patricia Williams-Bennett, who's the founder of the Williams Forum and is a specialist in the field of podiatry. We also have Dr. May de la Calzada, who specializes in both emergency medicine and toxicology. And last but definitely not least, we have Dr. Sandra Adams, an expert in the field of molecular virology. So now I'm going to give our esteemed panelists a chance to tell a bit about themselves and the work that they do. They are going to include some answers to questions that were presented by members of the community. So I'm going to start first with Dr. Williams-Bennett. And so Dr. Bennett, if you could tell me, good morning, if you could tell me a little bit about the impact of diabetes and other chronic conditions on our situation from a podiatry perspective.
Well, thank you, Dr. David, and thank you to my other colleagues for participating. I am a surgically trained podiatrist, and I am concentrating on diabetic foot care and wound care. So I want to speak to the audience about the complexity of diabetic foot infections, how they develop and how they can be prevented. Dr. David gave some information about the overall economic burden of diabetic foot infections. $327 billion a year. And this represents Medicare costs only. As you well know, there are many other insurance companies that are involved. Now, of this $327 billion, $9 to $13 billion per year is spent on diabetic foot infections and complications. Diabetic foot infections can render a person with the loss of the ability to walk, and with the hospitalization that can last for weeks and for months. The costs appear to be higher among men than women, perhaps because there's usually a delay in seeing a doctor. Women tend to visit doctors more often. Now, within the last 5 years, the economic cost for diabetic care has increased by 26%. We are moving definitely in the wrong direction there. Amputations have been found to occur 2 to 3 times more often in African Americans and in non-Hispanic whites. There can also be that implicit bias sometimes where the patient does not seek immediate care and also is not given enough options. So there appears to be a tremendous need for more diabetic education and more education for general health. Diabetes is the 7th leading cause of death, with over 270,000 deaths per year associated with diabetic complications, and a lot of them are correlated with vascular and cardiovascular disease. One of the greatest fears of a diabetic patient is limb loss. Elevated blood glucose levels, kidney disease, diabetic retinopathy, loss of vision are also complications. However, they are not always directly visible. The loss of a limb is visible. Within 1 year of diagnosis of diabetic foot infections, at least 17% of those patients will undergo major surgery. As Dr. David did explain, there are many complications of diabetes: retinopathy, visual loss, kidney disease, loss of limbs, cardiovascular disease. But there are several other complications that we won't even mention because the list is long. Diabetes is not a standalone disease. It is accompanied by many comorbidities. Now, in limb amputations, minorities, as I stated, are more likely to undergo limb amputations. Their presentation to doctors are often delayed. Sometimes it is because of socioeconomic depression, but also it's just a mindset. There's a failure to change lifestyles such as diet, weight maintenance, and to have regular medical checkups. How does this occur? One of the occurrences is obesity. Obesity causes the body to produce more glucose. Obesity also renders hypertension to be uncontrollable, and that in itself can lead to kidney failure. Increases in fat and sugar intake can cause elevations of cholesterol. Cholesterol can block arteries and affect blood flow. Now, ethnicity is directly related to nutritional preferences. Historically, salt, sugar, fats have been the mainstay of the African American diet and for many other ethnic groups. Flavor and texture are critical to their cooking habits and their palatable preferences. Now, returning to limb amputations, how does that occur? Dr. David mentioned neuropathy. Neuropathy is basically nerve damage. It is caused by an accumulation in the diabetic patient of excess glucose within the nerve linings. This prevents the nerves from firing properly. Therefore, the patient may lose feeling. Oftentimes, they walk around with a wound, an ulcer, or a sore. They don't even realize it because they have lost the ability to have that sensitivity. Therefore, most ulcers are not associated with pain. Generally, the patient will just recognize there may be some drainage, or they may accidentally see some drainage on their socks or in their shoes. That is one of the reasons we always advise diabetic patients not to walk without shoes. One small wound can develop into a massive infection. Open wounds allow the introduction of microbials and bacteria into the system. Wounds heal very slowly in diabetic patients because they have compromised immune systems, they have compromised vascular systems, they also fail to develop keratinocytes or new cells that are needed for wound repair. Wounds can take weeks or even years to heal, if they ever heal. Prolonged open wounds do not remain superficial. They eventually can invade bone and set up a massive infection that requires a long hospital stay. Continued pressure, walking on a limb, wearing improper shoes, can result in the breakdown of skin and the formation of a wound. Untreated ulcers can lead to osteomyelitis, which is a bone infection that is detected using various techniques, including an MRI. Blood flow in areas for a diabetic patient that is compromised can lead to necrosis, or what we call gangrene. Gangrene can result in an unsalvageable limb, a limb that can be saved and must be amputated. Limb loss not only affects a patient's lifestyle, but it affects an entire family socioeconomic status, and it affects those who have to care for the amputee. Depression can follow, and also the loss of additional digits or limbs. Diabetes is not controlled by a single medical professional. There is a large medical team that's involved in caring for patients with diabetes. That team is not limited, but does include a primary care physician, vascular doctor, podiatrist, ophthalmologist, cardiologist, rehabilitation specialists, nurses, dietitians, surgeons, and medical social workers. With any medical complication, prevention and early detection are critical, and this is particularly important in limb salvage. Every patient with diabetes needs to see their podiatrist at least twice yearly. Still, currently, in 2021, I still see patients who've had diabetes for more than 20 years, and they have never seen a podiatrist. It should be a normal part of the treatment regimen. Podiatrists, in addition to caring for nails, which can also lead to infection and digital loss, the podiatrist is assessing blood flow, pulses, skin temperature, skin integrity, all of these things that can be a first indication of a problem. If there are no problems with the foot, that is when we need to see you. Diabetic foot infections can be severe. They can be very difficult, if not impossible, to reverse. So therefore, there are a lot of basic rules for foot care. Although they appear to be mundane, they are essential to preserving limbs. Number 1, see your podiatrist regularly. Do not smoke. Smoking causes the accumulation of plaques in the vessels and impedes blood flow. Any impedance in blood flow can lead to tissue death, necrosis, gangrene, and loss of a limb. Never walk without shoes. As we said, most diabetics have developed neuropathy or a loss of sensitivity to the foot. They can have pins, needles, straws, and all kinds of objects in their feet, and they would never even notice it. They have lost the ability to detect foreign objects. Never have your feet near open flames, fireplaces, space heaters. Because of neuropathy, you can develop very advanced burn, which can also lead to necrosis, gangrene, and digital loss. Check feet daily. Check for color changes. Check for skin breaks. Never let anyone put sharp instruments on your feet unless it's a trained professional. Do not let your friends and family cut on your feet. I've seen many complications, loss of digits, loss of limbs, because the skin was nicked when a family member tried to cut the patient's nails. Never put creams and lotions in between toes. The vasculature is in between toes. It's very warm. You can have a breakdown of tissue, which is not recognized. Call your doctor if you detect swelling, cramping, pins and needles, formication, which is crawling on the skin. Wear proper fitting shoes. Have your feet measured. Most people just walk into a store and ask for a particular size. They haven't had their feet measured in years. I had a patient who stated that he wore a size 9 shoe. When he finally got his foot measured, he actually wore 13. However, by that point, he only had one limb. Loss of the ability to feel did not allow him the sensitivity to be able to detect that the size 9 shoe was too tight. Never put your feet in hot water without using your elbow or your hand to test it first. Again, neuropathy and loss of feeling can lead to third-degree burns and can cause the loss of a digit. Check shoes and slippers daily for splinters, foreign objects, pins. The neuropathic foot cannot detect foreign objects. And when you visit your doctor, always remove your shoes. A physical examination without an examination of the foot is not a complete physical examination. Properly monitor your diet and exercise. Remember, it is not a normal rite of passage to lose a digit or to lose a limb. If there is a need for an amputation, then something has gone terribly wrong with your treatment regimen. Diabetes is not just having a little sugar. It's a massive, complicated disease. Don't become a victim. Get educated, seek knowledge. Advanced wound care treatment can be done by professionals, hyperbaric centers and wound centers, by vascular teams, and by interventional cardiologists, if there is a need. However, you should not allow yourself to get to that point. There are very new, high-tech cellular grafts that can be used to close wounds, but you should know your medical team and you should know about facilities in your area. Prevention and education are key to good foot health. Conclusively, the rules for foot care will be posted on the website, www.wfdeh.org. And thank you for listening. You're invited to future health education forums. Thank you to Novo Nordisk and PSE&G for their support. And Dr. Park, back to you.
Thank you so much, Dr. Bennett. So Dr. Bennett, while you were speaking, you mentioned kidney disease. Can you tell me how kidney disease specifically affects the foot?
Yes, kidney disease is a vascular disease. Therefore, blood flow is compromised, and any compromise in blood flow affects peripheral areas, especially the feet and the digits. So patients with diabetes have complications, but patients with renal disease have more complications than diabetics because they do fail to heal.
Thank you. And also I've heard there's a new terminology, COVID foot. Can you tell me a bit about that?
Yes, COVID foot is the new term since the advent of the COVID-19 disease. The COVID virus has a propensity to cause clotting or disruptions in blood flow, and this significantly can affect the peripheral areas once again, the digits, the feet. And that's why you hear of patients with very advanced COVID disease having to undergo limb amputations.
Excellent. Thank you so much. That was really wonderful information.
Thank you.
Thank you. All right. So now I'm going to move on to our specialist in emergency medicine and toxicology, Dr. May de la Calzada. So Dr. de la Calzada, from this perspective of an emergency medicine physician, how would you say is the best way for patients with chronic disease like diabetes, high blood pressure, obesity, how can they empower themselves when they're going into the emergency room?
Thank you for that question. That's actually very good. So one way that patients can find themselves in the emergency department is, of course, for their chronic diseases. And in these trying times of COVID-19, and even before these times, patients can take the opportunity to reach out to their primary care physicians or their specialists to reach out to us in the emergency department so that we can facilitate their treatment. Oftentimes, many patients come into the emergency department, are lost in the shuffle, and feel that they are not treated with as much attention or dignity. However, please be aware that we are doing our best to take care of as many patients as we can.
Excellent. Thank you.
Thanks.
And regarding COVID-19 itself, what can you tell a patient about COVID-19 who might have to enter the emergency room?
Wonderful. One of the major questions a lot of patients ask is, when do I need to go to the emergency department, or when do I need to see my primary care physician? The most important time to come to the emergency department is when you notice that your oxygen saturation levels are dropping. Now, the only way to be able to recognize this is if you have a pulse oximeter. So we do recommend that a lot of patients go to their local pharmacy and purchase a pulse oximeter, which is placed on the finger and tells you what your oxygen saturation is. When that number drops to 92%, we do encourage everyone to come into the emergency department because there are treatments that we can offer early on in the disease process to prevent progression to moderate or severe disease. The goal with COVID-19 is to treat early and to prevent hospitalization and intensive care admission.
And so what is the first line of treatment in the emergency room for a patient with symptoms of COVID-19?
Absolutely. Depending on the severity of your disease, many patients do not know what their oxygen saturation is, so they come in with symptoms that are very similar to the common flu, whether it's fever, chills, coughing, shortness of breath, nausea, vomiting, diarrhea, abdominal pain, or loss of taste and smell. So when you come into the emergency department, we will assess your oxygen saturation, your work of breathing, and whether you require supplemental oxygen. If you are able to return home and quarantine at home, which in an ideal situation is the best option, we can offer a medication that's known as a monoclonal antibody. And the thought is that this medication can help decrease the disease longevity and also prevent individuals from coming into the hospital. This is a clinical trial that is active in the United States at this time. So we do ask for your permission to give you the medication.
All right, thank you. And moving on a little bit from COVID-19, for some other conditions, so say for diabetes, when would you say it's critical for a patient with diabetes to have to go to the ER?
Okay, that's wonderful. As far as diabetic complications, if your blood sugars, if you're a known diabetic and you have blood sugars that are out of control and you can't control them with your home medications and you're feeling sick, whether you have symptoms or not, please come to the emergency department because we can assist you with either modifying your medications or treating any clinical conditions that may need immediate assistance, such as diabetic ketoacidosis or hyperosmolar hyperglycemic syndrome. These are specific conditions where a physician may need to give you insulin, even if you do not require insulin at your home.
All right, thank you. And on to other conditions like high blood pressure. When would you consider it a hypertensive emergency that warrants a visit to the emergency room?
Hypertensive emergencies are defined as any blood pressure that's greater than 180 systolic and over 120 diastolic. And what do those numbers actually mean? The systolic and diastolic numbers are the two numbers that you see when your physician or a nurse measures your blood pressure. So the number on the top is the systolic pressure and the number on the bottom is your diastolic pressure. What do these mean? The systolic pressure is actually the pressure in your blood vessels when your heart is contracting. And the diastolic pressure is the pressure that is in your blood vessels when your heart is at rest. So when we say you have elevated blood pressure, we're speaking about the pressure going through the vessels that can cause end organ damage through repetitive pressure readings.
Oh, great. And can you tell me a little bit about a stroke and what would warrant a person to have to go to the emergency room with stroke symptoms?
Okay. So a stroke, there are two kinds of strokes. You can have ischemic strokes and you can have a hemorrhagic stroke. The difference between the two is that an ischemic stroke is a stroke that's caused by something that occludes blood flow to the brain. And usually we're talking about a blood clot in this case. There is also a hemorrhagic stroke, which is when, because of chronic disease, whether it is hypertension or diabetes or high cholesterol, can lead to disability of the blood vessel itself, and therefore you begin bleeding in the brain. When you start noticing that you have abnormal symptoms and you know that you have a chronic disease such as high blood pressure or diabetes or high cholesterol, you can look for symptoms such as a facial droop, when part of your lip is drooping to the side, weakness on one side, tingling sensations on half of your body, inability to walk, dizziness, or even a headache. So if these are symptoms that you've never had before, this is something that you would want to contact your primary care physician, and if concerned and you're unable to reach someone, to proceed to the emergency department.
All right, thank you so much, Dr. De La Calzada.
Absolutely.
All right, so now I'm going to move on to our expert in molecular virology, Dr. Sandra Adams. So, Dr. Adams, as an expert in your field, right now with the COVID-19 pandemic, what can you tell us about COVID-19, viruses in general, and the vaccines?
COVID-19 is the disease caused by a coronavirus. Coronaviruses are common viruses, and they are made up of molecules called RNA that are wrapped in a protein. And RNA is just an information storage molecule. It's a little different from DNA, which is what we have in our cells to store information. But coronaviruses normally exist in nature, and they can cause mild disease. As I said, viruses are very simple molecules. They're made up of genetic information. That genetic information is used to make the proteins that determine the outcome of an infection. You can contrast viruses to bacteria. Bacteria are living cells. Bacteria are capable of replicating, metabolizing energy, existing on their own. Viruses are what I call molecular parasites. They rely on living cells to replicate, to use your resources, to use your cellular machinery. Now, the virus that causes the COVID-19 disease evolved from other coronaviruses. It's closely related to SARS that appeared a few years ago, but it picked up some mutations. As I said, coronaviruses are made up of RNA for their genetic material. And RNA is unstable, which means it's very easy for it to mutate. Sometimes these mutations are harmful to the virus, but sometimes they're also very beneficial. Unfortunately for us, the virus that causes COVID-19 picked up mutations which are very harmful to us.
So can you tell me a little bit about the very basic steps in developing a vaccine?
To develop a vaccine, you have to first look at what is going to induce an immune response. As I mentioned, there's a difference between viruses and bacteria. With bacteria, you can treat them with antibiotics. Viruses cannot be treated with antibiotics. So it is your immune system that will stop a virus infection. So in order to create an effective vaccine, you have to find the right combination that would induce an immune response that would protect you from future infections, but you also have to make sure whatever is introduced into that vaccine will not harm the patient. So it's a delicate balance to find the right amount of information to produce in the vaccine that would induce an immune response and not cause harm. So there are different platforms for vaccines. Previously, vaccines used to be made up of weakened viruses or heat-killed viruses. The technology and our knowledge has advanced such that we don't have to make vaccines with intact viruses. The vaccines that have been currently authorized for use to treat the COVID-19 infections do not include any coronaviruses. Instead, these vaccines contain the genetic information that will produce that protein that you see when you look at an image of the coronavirus. That protein is called the spike protein. So both the Moderna vaccine and the Pfizer vaccine contain very little information, but that information is critical because once that information is introduced into your cells, it will get your cells to produce that spike protein. When your cells produce that spike protein, your immune system will respond. When your immune system responds, it will call up chemicals that are designed to, one, stop the spread of that virus within your cells. It's designed to kill those virus-infected cells, and also those chemicals are designed to also send a signal to another part of your immune system, and that part that makes antibodies and what are called cytotoxic T cells, which will actually kill viruses and virus-infected cells. But the problem is it takes a long time to develop those antibodies and those cytotoxic T cells. So when you receive a vaccine, the initial response is to identify the virus, begin to attack it, and send a message to the adaptive immune system, which will then make antibodies and T cells, which will kill the virus later.
So thank you very much, Dr. Adams. So how long does the viral immunity generally last?
Generally, viral immunity would be lifelong. Unfortunately, with this virus, we don't know how long the immunity will last. Right now, we know that it's up to about 8 months. Whether the immunity is longer than that, we don't know. This is an area of ongoing research. Unfortunately, as I said, this time we don't know. In the past, you could count on the fact that if you were exposed to a virus or a bacteria, you produced antibodies which remain and are there lifelong in the event that your body sees that pathogen or that virus or bacteria again. This time, researchers actually do not know how long the immunity will last to this virus.
All right, excellent. And we had a question from the community. Someone asked, stating that she's diabetic, should she get the vaccine?
Yes. Yes, that is a definite yes. This virus has severe complications for diabetics. The complications for diabetics are worse than any minor side effects that may come from receiving the vaccine. The research that we've seen now with the vaccine is that it is possible that there may be some minor side effects. Those minor side effects will disappear within a few days. The effect of a lasting infection from this virus are completely different and can be deadly. This virus can lead to severe disease such as pneumonia, respiratory failure, heart disease, liver problems, and death. And these complications are worse for diabetic patients.
All right, thank you. So would you say that everyone should take the vaccine?
I would say that everyone should take the vaccine. Right now, it is not yet approved for children under the age of 16, not yet approved for pregnant women. My advice for pregnant women would be to discuss this with your healthcare provider, because once again, the effect of the virus infection is much worse than the effect of the vaccine. So I advocate that everyone should get this vaccine, because if we increase the number of individuals in this population who are vaccinated, which means they develop some type of immunity from this virus. If you have a large percentage of the population that is immunized, then you reduce the number of susceptible individuals that this virus can spread to. In order for this virus to continue to persist, it has to have susceptible individuals. Susceptible individuals are any individuals who have not been immunized. That immunization would come either from a vaccine or from, of course, a natural infection. It is much better to be vaccinated to reduce the number of susceptible individuals that this virus can spread to. That is the only way that we would be able to reduce the incidence and come out of this pandemic.
All right, thank you again, Dr. Adams. Excellent advice.
Thank you.
Wonderful. I think we're towards our end here. I would really like to give a wonderful, huge thank you to our esteemed panelists, to Dr. Bennett, Dr. Adams, Dr. De La Calzada, and I'd like to thank you for sharing your expertise and your insights, and also to give a big thank you to the audience for listening. So if anyone has any additional questions or wants any more information, you can reach us at our website, which is www.wfdeh.org. Again, www.wfdeh.org. Thank you very much.